Yes, thank you for kind introduction. I'm Hoon Kim from Assam Medical Center in Seoul. It's my great honor to talk here today. And the topic I was asked to talk about is for the LDAT, but these kind of tumors involve the LDAT and DDAT as well. So today's topic is not only about the LDAT, but also include the DDAT. Okay, today now I'm gonna talk about the four of the different liver cancer, and I correlate the cancer liver mets, and the cholangiocarcinoma, and the epithelioid hemangioendothelioma, and the neuroendocrine and the tumor liver mets. For each tumors, I will review each cancer's transplant benefit, and from the recent clinical trial, and the patient selection, and the key treatment protocol, and the long-term outcome. And the first one is colorectal cancer liver mets. For this disease, and even for most of other cancer, a liver transplant considers only when the tumor is limited to the liver, and there is a strict selection criteria and clear the survival benefit. And the post-transplant immunosuppression should not the worst cancer's prognosis. In addition, obviously, there must be the transplant benefit compared to the resection group or the non-surgical treatment group. And the first pilot study on this liver transplant for unresectable and colorectal cancer liver mets was so-called the SICA-1 trial from the Oslo group, which is reported in 2013. This study included a small size patients, 21, and a patient with liver-only metastasis, and reported excellent survival outcomes. And the 5-year overall survival was 60%, even though there was a high recurrence rate. And this trial firstly to show that the liver transplant could be a feasible treatment option for unresectable and colorectal cancer liver met in terms of improving the survival. The Oslo group also reported the second trial, SICA-2 trial, in 2019. And the study included more strict selection criteria compared to the first SICA-1 trial. In addition to the liver-only metastasis, the patient additionally required good response to the chemotherapy and a smaller tumor size and at least 1 year the follow-up duration between primary resection and transplant. And the 5-year overall survival in these patients was 83%, and the 3 years disease-free survival was 35%, which is pretty better long-term outcome than the SICA-1 trial. And the Oslo group also developed the Oslo score to assess the risk for the long-term survival. And these scores include the factors such as large tumor size, the high tumor marker, and the short-term follow-up from resection to transplant, and the response to the chemotherapy. And each factor is counted 1 point, and the key finding was that the high-risk group with the Oslo score 3 or 4 and has significantly the lower overall survival and the higher recurrence rate. The Oslo group also reported the long-term follow-up data at the first SICA-1 trial in 2023. And the 5-year overall survival was 43%, and the 10 years overall survival was 26%. And specifically for the lower risk patient with the Oslo score 0 or the 1 point, and the 5-year overall survival was 75%, and 10 years overall survival was 50%. This long-term follow-up data, they clearly showed that the liver transplant, specifically in the carefully selected patient, the liver transplant can provide a real and a chance of the cure. Another trial is the Turner, the LDH trial reported in 2023. These trials compared the 3 groups, the transplant, resection, and the control group. This include the highly selected patients, at least 6 months of time after primary resection and a response to the chemotherapy and no vascular invasion. Just 1 week before the transplant, the surgical exploration confirmed there was no extra hepatic metastasis or lymph node invasion. In this selected patient, the 3 years overall survival was even 100%, and the recurrence-free survival was 69%. This trial also showed that the living donor liver transplant can be a good option for the highly selected patient. And so-called transplant trial is listed at a multi-center randomized control trial reported in 2024. It compares the combined chemotherapy and liver transplant group and the chemotherapy alone group. There is strict selection criteria included sufficient chemotherapy response more than 3 months, no metastasis, and favorable tumor biology, no viral mutation, low tumor marker, and good functional reserve. For these patients, combined chemotherapy and liver transplant group show 5-year overall survival was 57%, and the progression-free survival was 36%, which is significantly better than the chemotherapy alone group. And this group they emphasized the importance of tumor biology in the patient selection. There are several ongoing clinical trials for the current cancer liver mets. In the CICA3 trial, which is randomized control trial in Oslo group, their selection criteria included the patient with progressive disease or intolerance to first-line chemotherapy. And the Oslo group and German groups are now conducting a trial applying the repeat procedure. Another multi-center randomized control trial from the Sweden group, they select the patient with a good response to the chemotherapy. And as per the consensus recommendation for the colorectal cancer liver metastasis, it is recommended to wait at least 1 year from diagnosis to transplant. And if patient has a good response to the bridging therapy, the liver transplant should be considered at least 6 months later. And the liver transplant can provide a significant survival benefit in the selected patients in terms of improving the survival rather than the recurrent-free survival. And the chemotherapy response and tumor biology that should be considered in patient selection. And obviously, the most important factor for improving the survival is proper patient selection. And that's why the several studies are now still ongoing to find the best way to patient select. Okay, now let's move on to the second topic, and the cholangiocarcinoma. There are 3 types of the cholangiocarcinoma according to the anatomy, the location, intrahepatic and perihallar and distal type. The treatment strategy depends on the tumor's location. Firstly, let's take a look at the perihallar cholangiocarcinoma. For the perihallar cholangiocarcinoma, the initial experience of liver transplant so bad because there was no clear patient selection and the standardized neoadjuvant chemotherapy protocol. But at the turning point was came with the Mayo protocol in 2000. This protocol included combined neoadjuvant chemo radiation therapy. The result was very impressive. The 5-year overall survival was 82%, and this finding showed that the liver transplant could be the treatment option for carefully selected unresectable perihallar cholangiocarcinoma. This Mayo Clinic protocol included neoadjuvant external radiation therapy, brachytherapy, and a carfentanil-based chemotherapy and the staging operation before the transplant. For the perihallar cholangiocarcinoma, the liver transplant is considered under the strict indication according to the NCCN guideline. The tumor size should be smaller than 3 centimeters without any metastasis. And the Mayo Clinic protocols include confirmed diagnosis or the higher tumor markers with malignant structure, tumor size less than 3 centimeters, and no metastasis, and the negative staging operation finding. And according to the expert consensus, a liver transplant should be considered only for unresectable cases, and the neoadjuvant chemoradiation therapy and specific protocols are required. In addition, the arterial and venous jump graft should be prepared in advance for transplant because there are lots of cases of vascular invasion. And the next of is for the intrahepatic and the cholangiocarcinoma. And mostly this tumor is the mass-forming type and the node metastasis, and distance metastasis are so common, so the prognosis is so bad. There are no standardized criteria for the liver transplant, but the recent meta-analysis show that the liver transplant can provide excellent survival outcomes with the neoadjuvant chemotherapy, especially in the very early stage of this tumor. And the current management strategy it included gemcitabine and the cisplatin-based neoadjuvant chemotherapy and the surgical staging before the transplant. And currently, the transplant indication for this tumor is not still established. In general, the transplant candidate they should have the tumors on the liver, and the patient selection depends on tumor stage, liver function, and the tumor biology. And the liver transplant is recommended for the very early stage of tumor less than 2 centimeters, which is non-resectable cases because of the decreased liver function or cirrhosis. And for locally advanced cases, the transplant could be considered only in the cases of a good response to neoadjuvant chemotherapy and favorable the tumor marker. In European and US study group, they recommend the liver transplant for the intrahepatic cholangiocarcinoma only in the clinical trial in the case of the small and the single tumor, the less than 2 centimeters. According to the expert consensus, the upfront liver transplant is recommended only for very early stage of tumor, and in the non-cirrhotic patient with unresectable tumor, the liver transplant may be the option in the case of good response to the neoadjuvant therapy. However, the liver resection should always be the first line the treatment the option in the resectable cases. But transplant should be considered only for unresectable cases under strict protocol or the clinical trial. For the combined hepatocellular and the cholangiocarcinoma, the liver transplant indication is not established yet as well. There are several ongoing clinical trials on liver transplant for the cholangiocarcinoma. And a TransFit trial they compared the liver transplant group and resection group after neoadjuvant chemoradiation therapy for the perihallar cholangiocarcinoma. And the clinical trial of Toronto group is on the neoadjuvant bridging therapy for the early stage of intrahepatic cholangiocarcinoma. And the Tesla trial in Oslo group is on the liver transplant for unresectable intrahepatic and the cholangiocarcinoma. Okay, and let's move on to the third topic, the epithelioid hemangioendothelioma. This tumor is rare, the vascular tumor of the liver, and it's often huge size, multifocal, and it grows slowly, and it commonly spreads to lymph node and extrahepatic disease. And according to the ESMO consensus meeting in 2020, the expert group they recommend the liver transplant only for resectable cases without the extrahepatic metastasis and the tumor rupture. The previous retrospective study from the UNOS data they show that at a 5-year overall survival after transplant for this tumor was 77%. This survival outcome is similar to the HCC, the cases with the Milan criteria, and it's better than the outcome for the cholangiocarcinoma and neuroendocrine tumor. Another retrospective study from the US, the National Cancer Database, it is also showed that the 5-year overall survival after liver transplant was 62%, which is significantly better than the resection or non-surgical treatment group. The European transplant group increased the risk score to predict recurrence after transplant. It's based on the factors such as macrovascular invasion, the short waiting time, and hollow lymph node invasion. A low and intermediate risk group that showed acceptable disease-free survival compared to the high-risk group. In the algorithm of the management of this tumor, if the patient is a surgical candidate, and surgery is not done right away because basically these tumors grow slowly. Firstly, having the observation time for 2 or 3 months and retract the CT scan. If disease is progressive and there's no extrahepatic metastasis, the resection or transplant could be considered. And if the R0 resection is not possible because of the huge size or the multifocal disease, then the transplant could be the option. Okay, now move on to the last topic of today, the neuroendocrine tumor metastasis. Neuroendocrine tumor liver metastases are very rare, and almost half of cases are developed by liver liver metastases. There are 3 types of the tumor, type 1, 2, and 3, and based on the extent of tumor burden and metastasis. And the type 2 is the indication for the liver transplant, which involves the liver parenchyma less than 70%. And currently, the liver transplant mainly considered for unresectable and no metastasis and the slow-growing tumor. This slide summarizes the main criteria for the liver transplant for this tumor. And the Milan criteria, UNOS criteria, and INAS criteria. And all of them emphasize the same key point. And the tumor should be the well differentiated or low grade, no metastasis, and stable, and the controlled disease after resection. In addition, the UNOS criteria included and the stable the finding in the PET scan, and the INAS criteria include the patient with the diffuse lesion as long as they has a good response to the chemotherapy. The patient outcome within Milan criteria was so excellent, and the 5-year overall survival was 97%, and the 5-year recurrence-free survival was 87%. In another U.S. multicenter study, the patient with extra hepatic metastasis, they showed the post-transplant overall survival was 52%. And the European, the multicenter study, they reported the 5-year overall survival from the 60 to 80% after transplant, specifically in the low-risk group. So the most important point is the proper patient selection in this tumor. And the expert group, they recommend liver transplant for this tumor under strict selection criteria, specifically only in type 2 cases. Now I'll briefly talk about the immunosuppression and the cancer recurrence. And the CNI, such as tacrolimus and cyclosporine, that could be the double-edged sword because a high level of CNI increases risk of the tumor growth. And so the balance between the preventing the rejection and tumor the progress in the environment is the critical. The mTOR inhibitor, such as the sirolimus and everolimus, are known to have an anti-cancer effect. In the randomized control trial with the small sample size, sirolimus showed the lower the HCC, the recurrence, and improved the overall survival. However, so far, the most of the studies on immunosuppressive effect for the tumor recurrence, they have focused only on the HCC. So the data on the other tumors are very limited. As the liver transplant indication expand to the other tumors beyond the HCC, the future study are necessary to optimize the immunosuppressive regimen in various cancer. This is the conclusion. We can ensure the survival benefit from the transplant for the various cancer other than HCC only when we carefully select the patients under the clear and the strict protocol, considering the tumor size, metastasis, and biology, and adjuvant therapy, the response, and the transplant timing. This is the most important, the message of today. Thank you very much for listening.